Hi, welcome to Iron Health Talk with Dr. Akram. I am Akram. In this program, we'll be talking about all kind of different health issues with different experts in the field. Today, we're going to talk about cardiovascular disease, or generally you call it heart disease. So sit back, relax, and enjoy your time with us. Cardiovascular disease or heart disease involve the disease of the heart and the blood vessels. Atherosclerosis is the main reason, and this causes coronary artery disease, stroke, and peripheral artery disease. Risk factors include hypertension, smoking, diabetes, lack of exercise, obesity, cholesterol, poor diet, and increased consumption of alcohol. Hypertension causes about 13% of cardiovascular deaths in the world, and tobacco use is about 9%, and diabetes causes about 6% of cardiovascular deaths in the world. Estimated 90% of the cardiovascular deaths are preventable. Cardiovascular deaths are the leading cause of death in the world, except in the Africa. About 17 to 18 million people die annually of cardiovascular deaths, and this is preventable. In our special program today, we are going to talk with a specialist about all the deaths and how we can prevent it, because this is preventable, as I said before. So for that, please welcome our special guest on the show, Hossam El Gandhi. He's a consultant cardiologist in Essex. Hossam, thank you very much for being on our show.
Thank you for inviting me.
All right, how are you feeling today?
I'm okay.
Excellent. It is a good program because cardiovascular disease is very important.
It is very important. It's one of the leading, as you exactly mentioned, leading causes of death. But also, it's preventable, as you have just mentioned.
Exactly.
And it's devastating if it happened, not only because it leads to death, but if you survive it, you will not be the same.
You will not be the same. Okay. Before we start the program, let's talk about you.
All right.
Who are you?
Well, okay. I'm a cardiologist, as you just mentioned. I've been trained and working in this country for many, many years. I'm very I had other interests in medicine, and but ended up being a medic. So at some stage, I wanted to do music, I wanted to do writing, but I felt I'm not good at any of this, so I ended up being a medic.
So okay, that's interesting. So all these ambitions you had about writing and doing other things, you stopped it since you became a medic?
I didn't stop really, but I'm just trying to run parallel.
And you were telling about you've been traveling around and doing lectures and stuff.
Yeah, I got invited to many all over the world actually, and I also I like traveling in addition, but I go to many invited to many conferences, international conferences. I'm originally from Egypt. I go there frequently. I've been to also many charity kind of missions, if you could say, to do some cardiac procedures. Been to Sudan, etc. So yeah, been active.
Okay, very good. Anyway, this is a live program, so if you have any questions, you can call us on 0203 515 5788, or you can always write to us on our Iron Health Talk at irntv.co.uk, or you can also write in our YouTube channel or Instagram or Facebook link. Anyway, let's go to the program. Okay, why heart disease is so important worldwide?
I mean, you need to look at cause of death. I mean, 1 in 8 of men will end up with a heart attack and die from heart attack, 1 in 13 in women. So let's just concentrate in the UK. We have something like cardiovascular and cerebral vascular disease killing every 3 minutes 1 person.
Every 3 minutes,
every 3 minutes
dies
a stroke or a heart attack. But if you look at heart attack only, you got every 1 in 5, 1 in 8 minutes someone is losing his life. Wow. 63,000 deaths a year.
63,000 deaths in the UK only.
In the UK. And not only that, we get 100,000 people have a heart attack every year. Many people survive it, luckily.
Right.
And we have 1.4 million who are living now in the UK who had heart attack.
Heart attack in the past.
It's a big problem.
And this heart attack, it does not develop just there, isn't it?
Well,
It has been developing slowly for a long time because of
Exactly.
your habit and
exactly.
your food, obesity,
Exactly.
hypertension, diabetes.
Exactly. I mean, and it's also selective. So if you look at Asian population, they represent 60. So patients from South Asia, India, Bangladesh, Pakistan, Sri Lanka, Nepal, they represent 60% of victims of heart attacks, while they're only 17% of the population of the whole world. So you're talking fourfold higher chance.
Fourfold higher chance
Of
you
having-
being an Asian.
of being an Asian. It's not only that.
How is it for Middle Easterns? Is it same?
Well, it's the same, to be honest. I mean, there is no big, massive studies there. But I'm originally from Egypt, and I could
yeah.
tell you, I don't think it's any different. I think we share the same portion.
Okay, before we start, what went wrong here?
I don't think there's anything went wrong, but I think there is three factors which work against Asian
them.
Middle Eastern population. First thing is your risk factors. So you have prevalence of diabetes, you have the prevalence of obesity, you have the prevalence of hypertension in these societies.
Right.
You don't have the protective effect, unfortunately. You don't have the protective effect of sports. You don't have the protective effect of lifestyle.
Lifestyle.
And even if you claim many of the Asian communities are vegetarian, they're not really the vegetarian. They are eating grains, but they're not eating fruit and vegetable to protect.
So they are not eating enough fruit and vegetables to protect.
Exactly. So vegetarian is a good
That's a
thing,
very good point.
but you're not eating the right vegetarian stuff.
Right.
You're eating the grains. You're not eating the fruit and vegetable. You're putting lots of salt. You're eating lots of carbs. So add to this, we're not doing enough exercise at all. Weight is a problem. But there is a third factor which unfortunately you can't modify, which is genetic.
Genetic, right. So genetic is the one you can't modify, but there are lots of things you can modify.
Exactly.
Your lifestyle you can modify, your food habit you can modify.
Yes.
Diabetes, you can prevent it or you can reverse
Exactly.
it with time, or you can control it. High
Exactly.
blood pressure, again.
You can't control. So the risk factor you can't modify is male sex. You can't modify that. Being, your ethnicity, you can change that. Family history.
Yeah.
So if it's very interesting. I think anyone from the Asian or Middle Eastern community ask about family history, you will have many in our families have heart attacks. And if you have a member of your close family had a heart attack, your chances increase 3 to 4 times.
I keep telling this one. Like when I was young, when I was about, let's say, about 15, 16 years old, then I come from Sri Lanka, and
Right.
in our village, there was only one family who had diabetes.
Gosh. It's
So
interesting.
only one family by then, and everybody knew that family, and that was type 1 diabetes, which of course it is not depend on their lifestyle, which comes with the genetics, right? So
I mean,
what's
if you
wrong
look
with
at
the whole family.
patients who are, so it's a population of Sri Lanka,
Yeah.
and Sri Lankan who immigrated to this country, you will find that the prevalence of heart disease is much higher in the immigrants who came
Immigrants,
here.
of course.
Because genes remain the same, they come with you,
Of course.
but food have changed.
Food has changed, and that's what I'm trying to say. Now, in my village, every house has at least one person with diabetes, at least 1 or 2% with heart disease.
Exactly. So things have changed a lot. We are eating completely the wrong stuff. We're not moving as we should.
Yep.
And we are always standing in front of TV or watching our iPhone or whatever. We're not moving. We're not doing any sport.
And this is a really good point. I've been doing lots of program on diets and all these things recently for last 1 or 2 months, and try to educate people what they can really do. But these are the things you can change. The genetic you can't change, of course. You can't change your sex.
Exactly.
But there are a lot of things you can change and go back to that what you had before.
I think you can. I think you have to address to your plea to the medical director of every house, which is the woman in the house.
Yeah.
Because as you know, in these communities, the women have a very strong power. And they can actually direct the family to the right food and probably push the husbands to do the right exercise.
But our cuisine, you come from Egypt, Middle
Yeah.
Eastern cuisine, and the Asian cuisine are really nice. The food is really nice,
I know,
of course.
I
You
know.
can't deny that. And we eat a lot. Lots of rice and a little bit of curries.
So you strike the balance right, because the target is to enjoy life anyway. Enjoy your food anyway. But the right portion and the right stuff. And I think you need to strike the balance.
Yeah. I think, exactly that's why it's going wrong, because the big, huge rice plate, which brings a fast carbohydrate into the body, and that really surges this all the hormones.
Exactly.
And
I think as a cardiologist, I think the message is just, you need to try to keep your BMI to the healthy as much as you can, and eat the right stuff, and don't smoke.
Don't smoke. Smoking is one of the other factor, main factor. So we talked about prevalence in Asian people is high, exactly, as you said. Let's talk about the risk factors.
So the risk factors in general are, as I mentioned, smoking is a very strong risk factor. Diabetes is a risk factor, and it's widespread in the Asian community, as you mentioned. Hypertension is a risk factor, like physical activity is a risk factor. High cholesterol is a risk factor. Exactly. And there is the bad cholesterol that some people call it, and there is something called apolipoprotein. The small apolipoprotein is very prevalent in the Asian communities, have genetic link, and that again is a problem.
What is bad cholesterol when you say about it? How can we classify? What can we?
So basically, when you go to your GP, check your cholesterol, he'll give you a total figure, and then he'll tell you you have high density or HDL and low density, which LDL.
Right.
Apparently, the HDL is a good one, LDL is a bad one. And
HDL is the good one, LDL is the bad one.
But
low density lipo something proteins.
Exactly. And then there is something called apolipoprotein, which is really linked to a very high risk.
Right. Okay. So these are the things. So this cholesterol, it comes from your habit, your life habit, and your food.
In fairness, it comes from food, from genes. From habits. So you need to tackle it all.
What symptoms generally you should be careful of?
So, we all have seen these movies where and the actor crouch his chest and then shout, and the kids keep crying, and it ends happily or unhappily, I don't know. Or a woman had a fight with her kids, and exactly. and this is more or less, you get chest tightness, and the chest tightness is gradual, and you start to get it when you exert yourself or you're walking, and it gets worse and worse. At some stage, you just get it all of a sudden. In the center of your chest, you feel sweaty, clammy, pain goes to your neck, your jaw, your arm, and it's like impending doom of death, basically, if it is a massive heart attack. Now,
so it's mainly, if you talked about heart attack, so you have the pain on the chest, it is sudden onset?
Yes, the heart attack is more or less sudden, intense. This is the heart attack. But before the heart attack, in many patients, they used to experience symptoms, what we call angina symptoms, warning symptoms.
So this is the time you should be careful.
You should look
because you have time to play around here.
You have time to see your medic, your GP, because when you're going to walk into the supermarket and you start to have chest tightness in the middle of the walk, even if it goes away in a bit and the pain is like compressing your chest, sometimes goes to your arm, your jaw, then this could be angina.
It could be angina.
And could be a heart attack in waiting, basically.
Right.
However, you need to be careful, because it's not necessarily going to come across in everyone. And women are disfortunate here, because unfortunately it does not come as typical in women. So sometimes you just present with a lot of shortness of breath, sometimes even fatigue and tiredness. So there is no, as you know, in medicine, there is nothing black and white.
Nothing black and white.
No.
But your body tells you sometimes.
Your body tells you something, exactly.
So you have to listen to your body.
You have to listen to your body.
So if you feel that angina pain, and which transmit your hand and your jaw, so that's the time.
That's the time.
And once you get angina, it's always reversible, isn't it?
Exactly. So if you have these pains and you do the GP transfer you to the hospital, or you refer you to a cardiologist, and you do the investigation, and we find that you have angina or narrowing of the blood supply of the arteries which give blood supply to the heart, we can always reverse that. We can always open it up, either with tablets, either by putting a stent, which is a small tube we put in, or by different means.
By different means. But yeah, anyway, we'll talk about the treatments a bit later. I think we need to talk concentrate on more on these symptoms and how we could manage it at early stage, because main reason of this program is to prevent a heart attack.
Excellent.
Exactly, isn't it?
Excellent. So before even we go to the symptoms, we've spoken about prevention, we've spoken all the risk factors, and we've spoken about how we can reduce the risk factors.
Yeah.
Now, if you start to have symptoms, especially if you have one of these risk factors, a family member, you are a smoker, diabetic, etc., then you may get some concern. If you start to have chest tightness, which is worse when you exert yourself, or undue shortness of breath, palpitation, and then you will lose nothing by just checking yourself.
So palpitation, chest tightness,
mainly
and
chest
increases
tightness.
with exercise.
Exactly, but mainly chest tightness. In fairness, this is a typical symptom.
Right.
It's chest tightness, sometimes around the chest, radiating to the back, radiating to the arm, to the jaw, like a pressure, like a burning, which come with exercise. This is the angina symptoms.
So if we have these symptoms, what do you have to do?
I mean, obviously, it depends how bad is the symptom. So if you start to get them when you exert yourself, you need to see your GP as soon as possible. And he will refer you to the hospital.
Go to the GP first, right?
Exactly.
Okay, so that's fine. Let's see, in case, if someone get a heart attack, what will be the symptoms there? Because that is really important, isn't it? You need to get this person to the hospital as soon as possible.
You need to call 999 straight away.
999, yeah.
So this is more or less what you just mentioned, but in a more severe format.
Yeah.
So a pain which builds within a minute or two, usually in the center of the chest, like someone sitting in your chest.
You feel like someone sitting on your chest.
In most cases.
Yeah.
Very, very severe. Tightness, you won't be able to breathe properly, you start to become sweaty and clammy, feeling really unwell.
Sweaty, clammy, yeah.
And if you're known to have angina from before and you try the spray and it doesn't work, I think for 15-20 minutes you need to be calling an ambulance.
15-20 minutes, you need to call an ambulance.
And to be rushed to the hospital.
Okay, let's see. Now you're in the hospital. What happens to them in the hospital?
Loads of things. So basically, the ambulance crew will take you to the casualty straight away. You will have an ECG, which is in the beginning of the program. I've saw loads of ECGs. And,
lots of ECGs going on. Yeah, that's right. Yeah.
So you will have an ECG, which is electric tracing of the heart. So usually tell us if there is a heart attack happening or not.
So ECG will tell you, of course. Yeah.
And to be honest with you, this will even happen before you come to hospital. So the ambulance crew will do the ECG there and then.
Yeah.
And if they found particular type of heart attack, they will bring you straight to a hospital, which will take you straight to the cardiology cath lab, where we can straight away go in and try to open the blocked artery. So when the ambulance crew comes, they will do your ECG. And if the ECG is suggestive of the severe type of a heart attack, or something we call ST elevation, they will be rushed straight away to the cardiac cath lab. And because not every hospital has this one,
yeah.
and straight away opens the blocked artery.
So that's the main thing.
Otherwise,
what else can...
If it is not this particular type of heart attack, it's a slightly milder one, then a different procedure will take place. You will start it on some tablets, medication, but again, you will be taken to the
we
cath
can
lab.
dissolve the clot as well.
We are not dissolving, we can not dissolve the clot as such, but start some tablets to make things better.
Right.
And again, you will go to the cath lab. You can't escape from us. And,
right.
And then we look at the arteries and we sort it, but in a more kind of relaxed way, rather than there and then.
And there and then. So it is really important to reverse this blood flows, which is stopped. That's the main reason for the heart attack here.
I think yes. I mean, the main reason of the heart attack is one of the plaques, which are as atherosclerotic plaque.
The plaques which go and
have
block
just
them.
ruptured.
Yeah? Ruptures. Yeah.
And this means that the heart is starving for blood. It can't
Right.
get it. Therefore, it's shouting with pain.
Right.
And unless you go in and open it up, time is muscle. So every time you lose, you're losing muscle, and the patient could die.
Excellent. Okay, great. Let's talk a little bit more about all this to do with cardiovascular disease. And before that, we're going to go for a short break. If anyone joined the program now, what we're talking about cardiovascular disease, and okay, we got 1 minute more, right? Okay, let's talk
muscle,
about
yeah.
available investigation. So we said about ECG. Do we need to do an echocardiogram?
Well, no, immediately you have a blood test straight away to tell us if you had a heart attack or not. You will obviously have an echocardiogram at some stage to look at the heart muscle. We'll do all the blood tests, and I'm sure you're aware, and start some drugs to soften things and make the blood flow a bit better, and then give some patient painkillers to get the pain away.
Yeah, exactly.
And then get things ready for the next step.
And we give morphine as well, isn't it?
It's painkiller, isn't it?
Painkiller.
Not too much, though.
Okay, lovely. This is a time for a quick short break, and we'll see you afterwards. Thank you. Hi, welcome back to Iron Health Talk with Dr. Akram. Today in this program we are talking about cardiovascular disease. So far we have talked about the prevalence and what causes cardiovascular disease, and we have started talking about the investigation. In our show we have our special guest Hossam Al-Gandhi, who is a consultant cardiologist from Essex. But before we go to the next program, to the following program, there was a caller, a gentleman who asked me a question last week, and I had to do a bit of research. His question was bitter taste in his tongue. He said he had been feeling this bitter taste for a few months, and what was the cause. And I have looked in the literature and found out if you had COVID, there was a person who had COVID since last April, he still have bitter taste. That's one of the things. So after COVID, the bitter taste can last for a long time. Then dry mouth, not enough saliva, that's another possibility. Dental issues like tooth infection, cavities can also cause a bitter taste in your tongue. Then acid reflux is one of the major thing which you don't realize it, and that should be checked by a GP. Oral thrush or fungal infection, that's also another possibility. Or stress and anxiety also can cause bitter taste or metallic taste or salty taste in your tongue. Hope the gentleman is watching the program, and thank you very much for your call. Okay, let's go back. Let's talk about, if the patient who had heart attack or something, he's in your clinic, what do you do?
So if a patient presents with symptoms suggestive of angina symptoms to clinic, we always investigate him first. So we take a very good history. We do an ECG tracing. This all could guide us if really we have a high suspicion or not. If we're kind of equivocal, we go for some non-invasive testing, like put him on a treadmill.
So you put him on a treadmill, yeah.
Or even on an exercise bike, and we scan his heart in the same time, ask him to work hard, kind of create an environment where he usually gets the pain and see how the heart behave.
Right.
Sometimes even we infuse some drugs which could make the heart struggle a bit and go fast, something called the dobutamine stress echo. We scan the heart and see what's the response to this. And if the response suggestive of narrowing of the arteries of the heart, then we move a step forward to a more invasive testing. Sometimes we do something called coronary angiogram.
Angiogram.
Where we pass a small tube in the arm or the leg and under screening and to the origin of the arteries, inject some contrast under screening and see the arteries clearly. We can even do that now without going inside by something called CT angiogram. This is completely non-invasive. He goes through the CT machine and we could look at the arteries in 3D dimensions to diagnose if there is any narrowing in the arteries of the heart or not.
So those are the major things which will suggest where is the block.
Exactly. They confirm if the patient's symptoms are due to heart problem or not. And don't forget, because sometimes I was just heard you just talking about a patient who could have indigestion. Sometimes indigestion give you very similar symptoms.
Similar symptoms, that's
Exactly.
true.
So you need to do the tests, in a gradual and measured manner in order not to subject your patient to unnecessary risk. And if you are very suspicious, then you can do an angiogram and look at the arteries, and obviously that will give you the definite answer if there is really a narrowing which potentially could give a heart attack or not.
So once you see an angiogram, what time do you decide that's an urgent and you want to do a procedure and get this clot
Exactly.
out, or you want to open this artery?
So we are talking about a patient who came to outpatient clinic, not about a patient who presented with a heart attack.
Heart attack, yeah.
So the patient I saw in clinic, once I've done the angiogram and I saw the narrowing, if the narrowing is not bad, it's just like mild, we can just get away with some tablets. But if the narrowing is severe, like more than 80%, we sometimes consider something called angioplasty,
Right.
where it's more or less similar when we do the angiogram. A percutaneous procedure. It's not an operation. We just pass a tube in the arm or in the leg and take it to the artery and inflate a balloon and put a stent, which is a metal tube, and that usually sorts the problem.
Right.
If it is major narrowing everywhere, then he is referred for a bypass surgery.
So okay, the main reason, there is one way you could dissolve the clot with tablets, yeah?
It's not dissolves the clot. We're still talking about a patient presented in clinic with pain. If there is no clot, there is just a bit of a narrowing, like 30%,
Narrowing, yeah.
40%. There is tablets not to dissolve it, but to make things stable, like a cholesterol tablet or a
Right.
statin.
Statins, yeah.
And that usually make sure there is no more cholesterol going to the arteries again.
Arteries
and
again.
even sometimes make it less.
Right.
And there is some other different types of drugs to help the blood flow better.
Right. So the last option is the open heart surgery.
Exactly. So the last, if the patient, we can't do an angioplasty because there is loads of narrowings and the positions of the narrowings are not very suitable for a balloon.
Right. So not all the narrowings can be treated by this angioplasty.
Exactly. Sometimes the narrowing is as such, you can't open it with a balloon and then you go for a bypass surgery.
Oh, actually, we have a heart.
It just should be here and this should go to your end.
Exactly, yeah, I know.
Yeah, the skeleton should go to yours and the heart have to come to mine.
Yeah, I didn't realize that.
Maybe you want to be a cardiologist. Huh?
Yeah. So, okay. Treatment, stents, and we talked about open heart surgery. How to reduce the risk of heart disease?
Actually, it's very. I like actually you always coming back to the main point, because the most important prevention is better than cure. You say. So it's, as I always said, you need to be very careful. You need to be. We have to accept the fact that Asian community in particular have a very high risk of heart disease. There is no argument there. This is proven. You have 4-fold chance of heart attack. I keep repeating this. If you have a heart attack, you are 3 times more likely to have another one.
Just give me a minute, Hussam. There is a caller online. Hello.
Hello, Assalamualaikum.
Walaikum assalam.
Alaikum salam.
জি আমি থ্যাংক ইউ ভেরি মাচ আপনাদের প্রোগ্রামটা দেখছিলাম আপনাদেরকে অনেক ধন্যবাদ আমার একটু হার্ট প্রবলেম আছে মানে আমার কার্ডিওলজিস্ট আমাকে একবার নিউক্লিয়ার টেস্ট পাঠাইছিলেন তখন দেখছে যে ওনারা যে আমার আর্টারিটা একটু ন্যারোইং তো আমাকে সাজেস্ট করছিল এনজিওগ্রাম করার জন্য বাট আমি
Thank you very much. Keep talking and the studio will take this call and they will translate it for me. I understand that you have the heart problem and you said something about angiography. So this is really interesting question and we are really waiting for the studio to come back with the translation for us. Oh, can you talk in English?
Welcome.
Hello,
Thank
yes,
you very
Walaikum
much.
Assalam.
Thank you very much. I'm watching your program. It's very helpful.
Oh, thank
I'm
you.
a cardiac patient. I got a test. My cardiologist sent me because I got that angina pain, and he sent me for the nuclear test. And they said my artery is narrowing a bit, and I need an angiogram. But unfortunately, I have got CKD, chronic kidney disease, and they use those dyes. Maybe my kidney functioning go low.
Yeah.
But that's why I don't want to do that, because in my husband's case, it's happened. After his heart attack, his kidney functioning was low, and then it's become kidney failure. That's why I'm a bit worried, and I didn't go for angiogram. Then I used to go to Dr. Al-House, is an Egyptian or some other countries, Muslim countries, and he gave me those the GTN spray.
Yes.
And when I got the pain, I use it. And then again, my pressure is always very high. It's over 200, under 189, 90, like that. And it's not, I got 6 type of blood pressure medication as well. My doctor said because of my kidney function is low, that's why maybe this pressure is playing up. So he gave me another tablet. Instead of GTN spray, he says I can isosorbide or something.
Isosorbide, yeah.
Yeah, but when I had this medication, I got severe headache.
Yeah.
Then it's so unbearable headache. Then nowadays, I can't contact. I contact my cardiologist secretary and ask her. I told her about that, and she said she's gonna let me know if he can give me another medication. Change the medication. But she didn't reply yet, and nowadays it's very hard to contact them.
Okay.
But I don't know what shall I do. I stopped the medication to take it.
Okay.
Will it be all right?
Right.
Or is there any other medication instead of this one?
All right, sister. Okay. Thank you very much. It's a really interesting question. It's a very good question, actually.
Loads of good questions.
Shall we summarize?
So the summary is, obviously we can't talk specific cases, because I'm sure the doctors are giving very good care of their patients, and I don't know obviously more of the details, but I could talk in general. Yes, patients with chronic kidney disease. Sometimes, so the story goes, you suspect heart problem, and absolutely right to go for non-invasive testing, which does not test damage your kidney. Maybe it's one of these. So it's a nuclear test suggestive of possibility of coronary artery disease, and they suggested to do an angiogram. And the thing is, if you have chronic kidney disease, we use a dye or a contrast, which potentially could damage the kidney more, and she's absolutely right to be worried. But it's an equation of risk, and I'm sure if the cardiologist decided she needed an angiogram, there is precautions they take, like we give the patients full hydration, and
we give full hydration.
We give full hydration. We give, depending on what the kidney function like. Right. We give, and depending also how much you expect to find narrowing of the artery of the heart, which need intervention. So it's all about balance of risk benefit. But in general terms, I could only talk in general terms. If we are worried about the kidney, we usually give a lot of hydration to the patient beforehand to dilute the dye. Yeah. We inject a minimum amount of dye during the angiogram to make sure that the kidney function is not affected. Yeah. And that's how we usually do the angiogram in these cases.
So angiogram is possible. It all depends on the person's kidney disease, what stage it is.
Exactly, and also how badly the cardiologist wants the angiogram.
So if you did an angiogram, you want to find out something you could treat.
Exactly, 100%.
So you don't want to do just an angiogram for say.
So it's an equation of risk.
Her question was she's taking isosorbide. And that causes headache, isn't
Yeah,
it? That's
actually,
very
it's
common.
good and bad news because
Yeah.
the fact that it's causing you headache, that it is opening the arteries of your brain, and
So
it is
it
opening,
opens the arteries,
so it's
yeah.
opening the arteries of your heart as well. But some
Right.
people, so usually it get better if you tolerate it for some time. But if it does, some people can't tolerate it, and there is many different tablets around to replace it.
There
So
are many
there
tablets.
is loads of other tablets. So I'm sure a cardiologist will be able to find a different tablet if necessary. But as I say, every step have to be measured. We know it works in some patients. There is no this side fit all. Every step is measured, and there is always alternatives. Because we are not the same, we won't react to tablets as the same.
So on the end, she can always call her cardiologist. and
Absolutely, I'm sure.
If she can't tolerate the tablet, and
there will be an alternative.
there is an alternative.
And control of blood pressure obviously is very important.
Blood pressure is really important, isn't it? 200, 180 is quite high.
It is maybe because of the kidney
Because
as
of the
well. But again, its control is very important.
Excellent. Okay, thank you very much for your call. Okay, let's go back. And anyway, so we're talking about the risk factors.
Risk factors, as we talked about diabetes, we talked about smoking, family history,
Yep.
hypertension, we just spoken about it, and cholesterol. And you can always treat cholesterol with a statin.
Statins.
So, or different lipid lowering drugs. So it's important to get your cholesterol checked. Important to get your cholesterol checked, yes.
Are there anything to do with vegetarian diet, like a proper vegetarian diet? Will it reduce, or is it not?
Well, it is
always?
actually usually the vegetarian. I'm not vegetarian, but the vegetarian
Yeah,
diet
I'm
is
not vegetarian as well, but I'm reading more and more about it.
I'm thinking about it, but
Yeah.
but vegetarian diet is usually good news in general if you pick up your right vegetables. To be honest,
Yeah.
And yes, there is something about vegetarian diet. It's usually have a lower cholesterol with it, but there is no guarantees. Because there is a significant genetic factor which control your cholesterol. That's measuring cholesterol is important. And if the GP says that you need to be on a statin, you need to be considering this.
I think if you look at our ancestors, what we missed here, we're eating too much. We're quite comfortable. We're not doing enough walking around.
Exactly. I think it's very important that although we got it right, good things in a way, we actually, unfortunately, everything is give and take. We're not eating as he did. We're not moving as he did.
So do you think about any cardiac protective exercise or regime or something like that, or walking or cycling?
I think,
what can you?
Yeah, exactly. So I mean, I think walking, cycling, walking, swimming, running is always a good thing. But at a particular age, then you need. I usually say to my patients, say in particular age over 65 or whatever, they're walking 3 to 4 times a week.
3 to 4 times a week
At
walking?
least for 40 minutes. You walk fast.
40 minutes.
At least. But you walk fast to be able to walk, but you become slightly breathless, but not struggling.
Right.
So you can walk and talk in the same time. So we can do the program walking together. Akram will make us feel better as well.
Exactly.
So you can walk and talk in the same time. And if you do that, it's important.
So
It's
you
very
need
important.
to feel that
You
your
feel
heart is
slightly
pumping, yeah.
breathless. You cannot just
So
walk.
it's not like a stroll through the town center and you expect that you did
And
an
then you
exercise.
reward yourself with a drink and with food, and that is not really as a target.
Okay, what about these mothers? They always say, I don't have to do any exercise. I've been doing all this household work and...
It's a trick when you can ask you could get your partner to do the work in the house to say that. Well, actually, housework does make you lose some calories. Actually, so I encourage men to help their wives, and that is important in general. But no, seriously, housework make you lose some calories. But again, I think walking in the fresh air, designated time, 3-4 times a week into your system is important.
Okay, there's another caller coming on the line. Hello? Hello?
Hello.
Hello, sir. Yes, please go ahead.
Can I talk with studio?
You want to talk to the studio, yes?
Yeah.
Yeah, okay, we'll let you talk to the studio and they will pick up the call the other side and they'll come back to us. Anyway, thank you very much.
Okay.
Do you... Hello, you're on live television now. Hello, you can go ahead. You're on the program.
Hello?
Yes, sir. Please go ahead with your question.
Okay.
I'm Dr. Akram. I'm doing the show. You can talk to us, or you can ask my guest a question if you have.
Right. Assalamu alaikum.
Walaikum
Alaikum
salam.
salam.
Yeah, my name is Abdul Rahman. Yeah.
Yes, sir.
Yeah. I'm right. I'm a heart failure. I'm heart failure.
Yes. Yes, sir. Please.
I'm heart failure.
Yeah, you have heart failure. Okay, it got disconnected. Yeah. Okay, I'm sorry. I think the studio will pick up the call. Thank you very much. Okay, we got few minutes to go. Role of statins and aspirins.
So statin obviously is very important because it reduces your cholesterol, but also makes the plaque which you have in the arteries not vulnerable to rupture, reduce the chance of having a heart attack. So if the GP recommends statin, you need to consider that seriously. On the other hand, if aspirin, if the plaque rupture and the platelets and blood is getting sick, then the aspirin will also try to protect your arteries from being blocked. So aspirin is important. Now, you don't give aspirin to healthy people just to prevent a heart attack because everything have its side effects.
Yes.
But if only by recommended by your GP or by cardiologist, if there is a heart problem or a risk of stroke, etc.
Excellent. And let's summarize quickly. What are the heart disease in few minutes?
So we got a caller who
yeah.
couldn't finish. They talked about heart failure.
Heart failure,
is
yeah.
very important. You're talking about 1.3 million or just under a million. Actually, now it's just around 1 million population in the UK have a heart failure. The name is a bit frightening. The good news, there is loads of medication for heart failure, which make people live a very, reasonable and healthy lifestyle quality. And by the year, by the months, there is new medication to the market to improve the heart function. So it's very on heart failure when the heart is not pumping the blood properly. It's not getting enough, the brain is not getting enough oxygen, the kidney is not getting enough oxygen, so the patient is struggling with breathing. The new medication not only makes the patient feel better, but it gets the heart stronger. I remember when it was an SHO and a registrar, many patients, we put them for transplant, etc. It's not happening. You think the patient will
So
need...
there are lots of medications now.
Exactly. You think the patient will need transplant, you say the heart is absolutely no chance, 1 or 2 years down the line, heart is much stronger and patient is living much better. So there is loads of medication if you follow the medical advice and GP advice and your cardiologist advice. There is lots of management to heart failure. And this is another problem. There is valvular heart disease.
Valvular heart disease, yeah. That's
Narrow valves, which traditionally was treated by surgery. Now, as cardiologists, we treat many of these valvular heart disease without even doing surgery. You can treat them by passing a catheter from outside, passing the valve inside the heart without opening the heart, without opening the chest, which means a shorter recovery time for the patient, etc. Something called transaortic valvular implant. There is loads of advances in cardiology, which have transformed the practice completely.
That's right, isn't it? The open heart surgery is not very common as before.
Well,
now.
it is still there. I mean, it will play a very important role, but it's not for every case
Every case now,
So
yes.
many cases are managed without even having to open. But if you need an open heart surgery, it's not like movies again.
Yeah.
People are not waiting outside 50-50. It's actually a very standard routine operation. Exactly.
Hossam Al-Gandhi, thank you very much for
Thank you, Akram.
your presence here, and we have talked really important program here. This is all about this heart disease. It's very prevalent in the Asian community especially, but it's not only for them, it's all around the world.
All around the world.
Except Africa, but that's because Africans, they have more infectious disease. They die more of infectious disease.
Exactly.
Okay. Thank you very much.
Thank you, Akram.
Anyway,
Thank you very much.
Anyway, for all of you, today we talked about cardiovascular disease or heart disease, and somehow we managed to go through most of it and most of the prevalence of heart disease and the risk factors and what you could do if you have this one and how you could prevent it especially. Anyway, thank you for staying with us in Iron Health Talk with Dr. Akram. If you have any questions, you can always message us on our Facebook, Instagram, or YouTube link, and we'll come back to you with the answers, and we'll see you in a similar program next week. Until then, look after yourself. Thank you.